Lovely.
Hello, everyone. Restarting again. Wonderful event today. I'm really excited to introduce three of our speakers this morning. There's a lot to talk about, so we won't be pausing too much in between the talks and open for questions at the end. But today's focus is on antifungal stewardship, actually. And for those of us who do it, it is a complex domain, an emerging domain, and it is really nice to have two of our young leaders in this area. So Anna Khanina is one of our PhD fellows at NCIC, working on a fungal surveillance program, developing novel methods to undertake automated surveillance, and also has led the development of the antifungal NAPS, which she's going to show this morning, followed closely on her heels by Julian Lindsay, who's another emerging leader from Royal North Shore, who's over at the Fred Hutch at the moment, and really has been looking at emerging and novel evidence around monitoring antifungal agents, particularly in high-risk populations. And then at the end, I thought it'd be really nice for us to have some case studies about why it's such a complex area. So I've asked Beatrice Sim, who's our ID fellow at Peter Mac, to present some cases, because I think if you're not in that area, you really are presented with some very big challenges. And so part of the opportunity with the antifungal NAPS, with the educational materials that have been developed, it's going to be a really amazing way to upskill ID physicians, pharmacists, and other people monitoring these agents in their work. Before we start, I would like to recognise the lands on which we are on today, wherever you are, and respect those elders. And I'm going to start from next month on trying to perhaps show some Aboriginal artwork or that will reflect the importance of the land as part of our journal club each week. So I'm going to hand over to Anna to kick off.
Thanks, Kaz. Just get things started. Is that looking all right? Okay. So thank you so much for the introduction, Kaz. I'm going to talk about the antifungal NAPS. So that's an auditing tool that we've just launched just a couple of weeks ago for all hospitals across Australia to use. So what I'm going to do is I'm going to start with a little bit of background about why antifungal stewardship is important. How we went about developing the antifungal NAPS. I'll just touch on that briefly so that you know the background. We talk about how hospitals can go about performing the antifungal NAPS. I'll do a really quick demonstration, and I'll also just sort of touch on how you can get started. So in terms of a bit of background, fungal infections are really important infections. They are relatively rare infections, but when they do occur, they have really high mortality and high morbidity. And we are, as time goes on, seeing more patients that are at risk of fungal infection, more patients that are being diagnosed with cancer, undergoing immunosuppressive therapy for cancer or other conditions. And because of this, we're seeing increasing use of antifungals, both for the prevention of fungal infection, but also for the treatment of fungal infections when they do occur. And if these infections do occur, or if it's suspected that somebody has an invasive fungal infection, it can impact on the patient's underlying management. They may need to pause their chemo, reduce the chemo intensity. So we might be potentially influencing the management of their underlying disease as well. Across the world, particularly internationally, we are starting to see increasing resistance to antifungal agents, particularly triazoles, which is a concern for the future. As at the moment, we really only have limited treatment options, and there's not too many new antifungals on the horizon that are being developed out there by drug companies. And if a patient does develop an infection, the cost of managing that infection is quite high. There was this Australian study that showed that managing one infection in hospital costs around $80,000 for that patient. So, and the cost of antifungal agents is still quite high. So we need to be aware of that. So antifungal stewardship is really similar to normal antimicrobial stewardship. We have the same overall goal. We want to optimize antimicrobial use. We want to improve our outcomes for our patients. We want to reduce adverse events. We want to ensure cost-effective therapy and conserve the antifungals that we have today. But there are some added complexities for antifungal stewardship. And that is that patients with invasive fungal infection or who are at risk of invasive fungal infection can be really complicated. They can have lots of comorbidities, and it really does require expert input from people that really have good knowledge around diagnosis of invasive fungal infection, interpreting microbiology culture, non-culture results, and radiology results. People that understand the risk profile of these patients is, what we're seeing, does that match with the patients, what sort of therapies they've had, and are they truly at risk, and is this actually an invasive fungal infection? As I mentioned before, these patients have high mortality. There's also high toxicity from the antifungal agents that we have at the moment. There's lots of drug-drug interactions to consider and limited bioavailability. And I think that's a really key area for pharmacists to get involved to ensure that we're prescribing the best agent in the best way for each patient. And also here, building relationships with primary teams is important. It is important in AMS, but even more so in antifungal stewardship. You want to have your hematologists, your ICU physicians, your solid organ transplant physicians on your side, and to be aware of what activities you're doing for antifungal stewardship, so that when it comes to implementing change, that they're on board and that they're supportive and that they can help to drive those changes. In 2020, there were some core recommendations around antifungal stewardship put out by a European group, and one of their key recommendations was that it's really important to evaluate the quality of antifungal prescribing. But at the moment, there's not really a set way to do that. There's lots of different studies. Everyone's doing it slightly differently, so it's hard to compare between different studies that are doing it, different people that are doing it. So it's hard to really compare quality from one hospital to the next. So we want to develop a specific module to look at antifungal prescribing, and we had a look at the existing hospital NAPS to see, what are the gaps, what are the limitations, and what can we do to improve what we have at the moment to allow a deep dive audit for antifungals. So we found that, unfortunately, the hospital NAPS, it's a point prevalence methodology, which works really well, but for antifungals, you tend to get really low volume of antifungal prescriptions on a particular day. If you're auditing, you might get a few prophylaxis and maybe a couple of treatments on that day. It also only allows you to assess prescribing at one point in time. So you're not able to look at the patient through their journey from when they perhaps came into hospital on prophylaxis, when they developed a suspected infection and started on empiric therapy, and then when that became directed therapy for their confirmed infection. Also, the hospital NAPS currently doesn't collect data on patients' history and their risk factors for invasive fungal infection. So when you're interpreting the data, it's hard to know were these patients at risk, who were these patients that developed infection. So also, there's no metrics that are specific for antifungals. It doesn't look at things like whether or not TDM was performed, are there any significant drug interactions, and there's no outcome metrics. So we're not able to assess, the rate of invasive fungal infection, rates of breakthrough infections, and mortality as well. That's why we need this antifungal deep dive audit, which is what we've developed. So I'll give a brief overview of how we went about developing the antifungal NAPS. So we started off with doing a really extensive literature review to understand what quality metrics, audit tools, and methodologies currently exist. And we found that there's a lot of different ways that people are doing this across the world, but there's no consistent way and there's no validated way to do this. So we went on to do what's called a Delphi study of international experts, where you go through a couple of rounds of asking questions. What we determined what were the important and the feasible metrics to measure antifungal stewardship activity, and we came up with a list of about 22 important and feasible metrics to use. We then went about a co-design, a multidisciplinary steering group together of physicians and pharmacists from different areas to develop, and epidemiologists, I should say, to develop the content, taking on board what we found in literature search, what we found from the Delphi study, to design what was going to be in the antifungal NAPS. We then went about developing it. We piloted across 8 hospitals across Australia who tested out the methodology, the usability, and they provided us with some really valuable feedback, which we then went back and took on and made some changes. And we've also done what's called a validation and reliability study, which I'll talk on briefly, but do I have slides on that? Yeah, so what we did was we developed some case vignettes of antifungal prescribing in 4 areas: in HEMONC, ICU, solid organ transplant, and pediatrics. So it's like a description of a case. We then had a steering group that came together to determine what was the correct answer for appropriateness and guideline compliance, based on the information that was provided, based on the guidelines and all of the tools that we had developed for the antifungal NAPS. We then recruited external assessors, some of which I saw in the audience, to do an assessment of these same case vignettes to rate each prescription for quality, for appropriateness and guideline compliance. We sent them out a survey, and then we compared how well the external participants did compared to what was our steering group had decided was the correct answer. And so what we found was that we had quite good accuracy. About 77% of the time, the external people got the right answer, and we had really high sensitivity of about 85%. And that showed that when a prescription was appropriate, they did a really good job of identifying that appropriate prescription. But we had a lower specificity of about 67, 68%. And that showed that when a prescription was inappropriate, they were less able to call it inappropriate. And then we did a bit more of a deep dive to try to understand why and what were the barriers to the correct assessment. And actually, a lot of the time people were using the antifungal NAPS appropriateness matrix, which I'll show you shortly, incorrectly, unfortunately. They might have found, oh yeah, that dose is too low, but they still called it an appropriate prescription, even though it was, according to our matrix, it should have been rated inappropriate. There was lots of that happened. There were some key knowledge gaps that we identified, for example, caspofungin use and dosing in hepatic impairment, or fluconazole dosing when you've got a sensitive dose-dependent Candida organism. Some people had a lack of familiarity with some prescribing areas. Some AMS pharmacists didn't feel confident in assessing a patient's risk of invasive fungal infection, so they weren't able to accurately or confidently say that this person is at risk and therefore they do need prophylaxis or they don't need prophylaxis. Sometimes people found that where there wasn't a clear guideline, they had difficulty doing an assessment, and sometimes they had difficulty interpreting the guidelines that we have available. Sometimes they missed a fine case detail. There were a couple of cases where everyone kind of missed a really small point, and therefore everybody got it wrong, which was interesting to see. Sometimes the cases were just complex, and actually sometimes that the assessors found issues that the steering group hadn't considered, and maybe our gold standard wasn't quite as gold as what we had hoped it would be. So we really learned about how we could improve the antifungal NAPS from this study, and we found that what we need to do is we need to make sure that people are using the appropriate matrix correctly. And so online, if you say that someone has an incorrect dose or an incorrect route or spectrum is incorrect, that if you go to say that that prescription is appropriate, you're going to get a warning so that you reconsider and that you hopefully downgrade the response to inappropriate. Any sort of key knowledge gaps that we found, we're going to be incorporating we incorporated our e-learning module, and in some of we developed some case vignettes as well, some worked case examples to highlight these knowledge gaps. And really we found that the different types of assessors had their own skills and strengths. So we had specialist pharmacists, so pharmacists that specialize in oncology or transplant or ICU or pediatrics, that they were really, really effective and really accurate. AMS pharmacists were really accurate as well. And then ID physicians were a little bit less accurate. But by working together as a team, you're bringing together knowledge from different domains. And so we really do encourage everyone to do this sort of auditing as a team, even more so than you would for antimicrobial stewardship audits. So this is what we've come up with. We have the antifungal NAPS. It's a flexible audit methodology, which I'll talk about. We assess each phase of antifungal prescribing. It does collect information about IFI risk, so you can risk stratify these patients. We've added in some new quality metrics that are specific for antifungals from the Delphi study. We have important outcome metrics, and you will have the ability to do some reporting and benchmarking. So who should be involved? As I mentioned, we really encourage it to be a multidisciplinary team to involve your AMS pharmacists, your ID physicians, but also to involve your specialist pharmacists. So if you've got your hematology pharmacists, your ICU or your transplant pharmacists, get them involved in the audit as well, because they bring a different set of knowledge and skills that can help to assess these appropriateness and also to then implement change. And also not to forget your specialist physicians as well, because if you're going to be able to make change with the results of any audit that you do, you want to have them on board so that they understand what you're doing, why you're doing it, and they can help you to disseminate those learnings and hopefully make change for the better. What can you audit? So as I mentioned, it's a flexible audit methodology. You can choose to audit all of your antifungals in your entire hospital. Or you might want to say, I want to look at what's happening in our ICU and I want to audit all of our antifungals prescribed in ICU. Or you might focus on a drug. You might be, you're seeing a lot of ambisome being used and you're wondering, is it being used appropriately? So you could focus on just your ambisome across your hospital. You might be interested in all of your voriconazole, posaconazole prescribing. You can choose to focus on those. You can also do it by patient type. So for example, you might be interested in what's happening in our acute leukemia patients, and you might choose to audit 30 consecutive patients that have been newly diagnosed with acute leukemia, for example, or bone marrow transplant, or some sort of solid organ transplant as well. Or you can audit by indication. So you might be interested in what's happening with all of our candidemias in our hospital. Are we managing them appropriately? Or how are we doing with our prophylaxis in our high-risk patients? So it's quite flexible. We are doing our first national benchmarked audit. So every year we're going to aim to do a different kind of benchmark, because there's such a different variety of ways that it can be used. So if one hospital is doing auditing of their heme patients, somebody else is auditing their ICU patients, somebody else is doing the whole hospital, it's really hard to benchmark and to compare. So for our first benchmark audit, we're encouraging hospitals to take part and to audit either all antifungals at your hospital, and if that is too high a workload, to focus on ambisome, and then mold active azoles, and then echinocandins and others. So you might just say, we just want to do ambisome. We don't have enough resources. Or maybe we want to do ambisome and our mold active azoles. That's what we're interested in. So we're hoping that everybody can submit their data to us by the end of February. So that allows around about 5 months. So we can then gather the data to do some analysis. So quickly, I'm running out of time, but I'll quickly just do a really quick demo. So Antifungal NAPS is accessed through our normal NAPS website. You log in, or if you don't have an account, you can register. So you notice the Antifungal NAPS doesn't have its own tile here. It sits within the hospital NAPS. So to access it, we've got all of our resources here. So you'll see we now have some Antifungal NAPS user guide, a data collection form, our appropriateness matrix. So we've got some worked case examples that I think are really worth having a look at, and the instructions for our national benchmark audit. And we've got an e-learning module. So this is something that you must do before you're able to finalize any data. But my suggestion is that should be your starting point, and go there first, do the e-learning module, have a read through the user guide, look at the data collection form, look at the case examples before you get started, so that you've got a good knowledge and that you can do it consistently and accurately. Then to create a survey, you head over to My Surveys. You go new survey, and then make sure that you choose an antifungal NAPS methodology. You pop in the name. So demo, and today is the 19th of the 10th, just as an example. You pop in the date of the audit. Got some optional fields there. So once you've created your audit, you then go over to patient data. You find that audit in here. That's the one there. And you add a new patient. And then what we've got here is we've got your patient details. So you've got additional things that aren't in the hospital NAPS, such as primary immunocompromising conditions. So if they have a hematological malignancy, you'll then also state what type of malignancy they have, what current therapy they're receiving, and what their risk of fungal infection is. And that we've got a link there to help you to make that risk assessment as well. Then you move on, and we have a page around adverse drug reactions, drug interactions, allergies, and contraindications. So is there anything that's prohibiting the use of an antifungal? You would document that in there. We've got antifungals, so you can actually say that there's been none prescribed. Say you're auditing all of your hematology patients and somebody isn't on an antifungal, and that may or may not be appropriate, but if they should be on a prophylaxis, then we can capture that data as well. And if an antifungal is prescribed, you can pop in all the details here as well. So depending on the type of course, if it's prophylaxis or empiric or directed, you'll get additional questions, and you can enter that detail here. We've got process measures, information about adverse drug reactions, and assessment of prescribing. And finally, we have an outcome data page looking at mortality, and if they do have an invasive fungal infection, whether or not it was a breakthrough infection, how was it classified, and what was the treatment response. Once you finish with that, you finalize the patient and you go in and add a new patient. that was a really quick overview. And this is our appropriateness matrix. It's similar to the hospital NAPS, but there are some slight modifications specific for antifungals. I should say that we are doing more detailed demos. They have a detailed demo later today at 3 p.m, which you're absolutely welcome to join. It goes through some of the background, but much more in depth around how to enter the data and the data definitions, and so it could be worth coming along. I'm also running a session over the next few weeks as well. So I'll pop in a Zoom link for those if anybody wants to come along. And just how to get started. So make sure that you put together your multidisciplinary team. Make sure that you incorporate not just your usual AMS pharmacists, ID physicians, but you get your specialist pharmacists, your specialist physicians involved as well. Determine what you're going to audit. Are you going to focus on a drug or a patient group or a particular time period? Make sure that you do the e-learning, download and review the resources that we have, and then begin auditing. And you can do the data collection on paper, or you can go and do it directly into the website as well. And these are our collaborators, and that's all I have today. And yeah, if we have questions afterwards, I'll be happy to take them.
People can also pop comments into the Q&A and we can answer them online as we go through. Thanks, Anna. It's very exciting, and I encourage people to come in and have a bit of a deep dive with Anna during the detailed sessions. So moving on to Julian.
Thank you very much, Kaz. And firstly, well done, Anna, for putting together that NAPS. That's an absolutely incredible resource for everyone to have. Hopefully you can see my slides now. I'll just assume we can. So for those that don't know me, my name is Julian. I'm actually a BMT pharmacist from Australia originally, but I've taken some from North Shore Hospital, and I've taken some time off to conduct a PhD through the NCIC in Seattle at the Fred Hutch Cancer Center, which is a very big cancer care, especially hematology and bone marrow transplant center in Seattle. So today I'm going to briefly attempt to, in 15 minutes, do a very brief journal club from a journal that came out recently by Logan et al., which is a multi-site evaluation of antifungal use in critical care. So the implications for antifungal stewardship in the ICU. So this was published a couple of months ago in JACC Antimicrobial Resistance. And then just sharing a little bit of preliminary data from a study that I'm conducting at the Hutch, which is the incidence of antifungal disease during an induction for AML chemotherapy regimen called GCLAM or CLAG-M. So I'll kind of try and keep both brief. So Logan et al. The aims of this study was to guide the development of the local stewardship initiatives in the ICU and the evaluation of antifungal prescribing, IFI incidents in 3 critical care units in London. So essentially, this was St George's, King's and Guy's ICUs, and it was a snapshot over a May to November of 2019. If you total the ICU beds, it was 165 beds. So it's a pretty good evaluation of the UK ICU system, which I feel is fairly similar to Australia's. They evaluated the consumption, prescribing rationale, post-prescription review, de-escalation, and IFI diagnostic classifications. So their results, they had 4,000, in that time period, they had almost 5,000 patient admissions or 25,000 bed days equivalent. And out of those 5,000 patients, there were 305 patients or 6.4% of all ICU admissions with 1 or more antifungal drugs. And so this equated to about 371 antifungal drugs or prescribing episodes. And over the period they looked at, that equated to 2,800 days of therapy. So it's a really good snapshot to find out what was happening. Now, in the summary of their results is here. So you can see, as we talked about, 371 prescribing episodes. Now, I find the rationale for this antifungal therapy quite unique to the ICU, especially in my background coming from hematology. You can see that 50% were empirical 12% targeted, 8% preemptive. So there's actually a lot more empirical and treatment antifungal usage going on in the ICU than, say, a hematology ward or a cancer care unit, where there'd be a lot of prophylaxis that's very guideline driven and doesn't need too much monitoring or intervention. And I think that's very relevant for this paper as opposed to other papers that have come out before. Similarly to duration for prescribing, so empirical was 7 days, but then that would often then change to a targeted, which was a median of 15 days. Prophylaxis was 11 days, and remember, this is just their ICU admissions, so how long they were on the antifungal drugs while they were in the ICU. Consumption, there was actually quite a bit of echinocandins. So most of the use was actually echinocandins and fluconazole, with actually only 10% being mold active azoles, but that same proportion being amphotericin, which I found quite interesting. And that sort of makes sense with the fact that a lot of the use was empirical or targeted therapy. And then that's just a little diagram they put together. So this is the use of days of treatment per 100 occupied bed days of ICU. So the suspected or confirmed invasive fungal infection, majority of the use was that targeted preemptive empirical therapy. And the majority of that was echinocandins and fluconazole, with green being mold active azoles. Very few mold active azoles were being used in that space. However, in prophylaxis, that would be where you have a hematology patient come in, they're on those mold active azoles, and so that's where the majority of the use for them are. So there's a few results that I sort of pinpointed. It's a really good summary if you're in the area and want to have a look. I'd highly recommend it. They do talk about some other small results that came through, and I just picked the large things, but I found this was interesting. So 217 patients received antifungal therapy for suspected or confirmed IFI. So that was 12, 10, and 23% for possible, probable, and proven IFI. Hence, as they sort of published, 55% of those IFIs for empirical or for treatment were unlikely, or at least not classified as the EORTC classification of even possible fungal infections. But I will come to that in a minute. But that it's a lot of treatment doses for not having that diagnosis there. Proven IFI was mostly candidiasis, which in ICU sort of makes sense, of which 50% had been initiated on empirical therapy before then moving on to that treatment when the results came through and it was confirmed. 85% of episodes were at-risk hosts with a median of 3 of the following factors. So they were either intubated, RRT, ECMO, TPN, CVC, surgery, solid organ transplant, hematological malignancy, or immune suppressive therapy. So it's pretty easy in ICU to have 3 or more of those at-risk host factors. So that sort of makes sense. And that really demonstrates how much this is a high-risk group for this particular, like for antifungal stewardship to be implemented. Now, there was a post-prescription review of 80% of the prescribing episodes, and the most common advice was to send for investigations. So 58% of their advice, or 121 of the reviews that they did, were telling the teams to send further investigations, which actually comes back to my point of 55% of the patients they reviewed actually did not have a possible, probable, or proven IFI diagnosis. And that doesn't necessarily mean they didn't fall into that category of having one of those things, but there wasn't the appropriate investigation sent. So it's really starting to show how antifungal stewardship can benefit the total treatment of the patient. Recommended durations of therapy were 40% of the recommendations, stopping antifungal treatment were in 38%, and starting antifungal treatment was in 38%. So it's definitely different to that sort of historical antifungal stewardship just tells me to stop my drugs early. They're actually telling people to start drugs at the same rate as stopping drugs, which I found was quite interesting. And switch to alternate drugs at 20%. Where a suspected IFI was not confirmed, 40% of those episodes were stopped and 4% were de-escalated. So obviously there'd be a huge cost and resource allocation for that. And in conclusions, the study said that in-depth evaluation of antifungal in ICU has highlighted areas for focus of antifungal stewardship, and I definitely agree with that. Optimizing antifungal therapy prescribing to achieve better balance between early treatment and those with IFI, avoiding excessive empirical therapy, requires a multifaceted approach. And that's, I think it's a good journal for showing that. And if it's in your area, I definitely recommend having a closer look at it. So in the next 5 minutes, I want to show you some very, very new data. So this is sort of, I mean, these graphs I'm going to show you came about this week. So we're talking very new. And it's looking at the antifungal IFD or antifungal incidence of using CLAG-M. So this is part of my Fred Hutch study. My primary supervisor here is Professor Josh Hill, and my supervisor is Monica Slavin. So thank you both of them for letting me discuss the results. So CLAG-M or GCLAM sounds kind of weird, but if you have been in hematology before, you might be familiar with FLAG, an intense induction regimen, and it's actually similar to that. So instead of fludarabine, they use cladribine 5 days in a row, and then it's followed by a big dose of cytarabine, sort of like a HiDAC. And then instead of idarubicin, if you're giving FLAG-IDA, it's mitoxantrone for 3 days. Now, this is sort of the standard of care now for all AML upfront and some MDS at the Fred Hutchinson Cancer Center. 7.3 sort of was stopped used around 2016. And there seem to be, there's a lot of trials still with it, but there seems to be better outcomes by hitting them harder up front. Now, the main differences between using this and just 7.3, which most people are familiar with, is the neutrophil recovery is a lot slower. It's much heavier upfront therapy. And so the neutrophil recovery up to 0.5 or 500 microliters is 26 days. So interquartile range of 23 to 30 days. And then they will either have a reinduction with another CLAG-M or have a CLAG consolidation. So without the mitoxantrone, which the neutrophil recovery after that is 30 days with a range of 26 to 36 days. So we're talking about a lot longer period of neutropenia, and it's definitely clear that there is a higher risk of invasive fungal disease. So what we wanted to do was to look back at all of the patients that have been treated with this, use a 7.3 historical control arm to sort of try and give a comparator and look at all of the proven probable as well as possible incidence of IFD. Now, we also had to include an objective of considering prophylaxis. Now, this was important for 2 reasons. One was because the study went from 2006 to 18, so it's a very large period of time. And a lot of those 7.3 patients between 2006 all the way up until 2012 were only given fluconazole prophylaxis. It was before the evidence of posaconazole came out in that 2012 to 14 period. And you might think, oh, this is really intense. How were none of them given prophylaxis? When I say prophylaxis for this study, I mean mold active azoles. So fluconazole or an echinocandidin is considered not prophylaxis, and prophylaxis must have been started within 14 days of the first day of chemotherapy. If they sort of withheld and they were on a new targeted agent in combination, like midostaurin or sorafenib, and it was withheld for those reasons, that was not considered adequate prophylaxis. And so when I'm talking about the results, that's the definition that I'm using. So we looked at new disease, relapse refractory, and the control arm of the 7.3. Now, demographics, you can see, so it's a little bit small, but essentially there were 330 CLAG-M patients, and we found 115 7.3s to compare it to. So it's a really great big cohort of sort of 450 patients. And it's kind of what you would typically see. It was 80% AML, some MDS. And as I explained, most of the 330 CLAG-M patients, 30% had another CLAG-M reinduction, 50% had a CLAG consolidation. And of the 7.3, most of them got a HiDAC consolidation afterwards. So that's pretty much the standard in Australia still, I think, a 7.3 and then HiDAC. And as I explained, not many of the 7.3 had a mold active azole as prophylaxis. Most were still on fluconazole. 20% had VORI or POSA back then, whereas between 60 and 70% of the CLAG-M did have prophylaxis. And like I said, a lot of the ones that didn't were people that had an echinocandin or fluconazole, mostly because of drug interactions, although over here you also have the worries about health insurance not covering, which is very frustrating to have to work with. So the main preliminary results so far, and this is, and keep in mind, this is such good evidence for antifungal stewardship. So the dotted lines are those of the 2 cohorts without prophylaxis, and the solid lines are with prophylaxis. So of the without prophylaxis, there was 100 of the 7.3, 142 of the CLAG-M. So 7.3, there is an argument still that you only need fluconazole. Other than the big Cornelli paper, a lot of centers still don't think that the use of a mold active azole has a impact on survival. It's sort of, in Australia, it's very much posaconazole because everyone can get it easily, but definitely here, if people can't afford it, then they don't get it. And there's what you would expect to see with an incidence of around 5 to 7% at day 60 or day 90 of IFD. Now, keep in mind, the numbers get really small after day 90 because we censor them when they go to allo transplant. So we don't want to be looking at results post-allo. This is just their course of AML, the inductions, consolidations, and then when they go to transplant, they're censored. That's why the numbers drop very rapidly from like 100. We're still looking at 70 patients at day 90, but by day 180, there's only 18 left. So that's why I'm sort of concentrating around the day 90. Now, without prophylaxis for the CLAG-M, on the other hand, we're talking about a 28% incidence of proven probable IFD, which is just a huge proportion and is, it's just not, it's quite profound. Now, looking at prophylaxis, like I said, with a mold active prophylaxis started within 14 days of therapy, whether it's the CLAG-M or the 7.3, we're talking about very low rates of less than 10%. Now, that's still somewhere that we can improve on, but it's substantially less than with prophylaxis. So it really goes to show that appropriate antifungal prophylaxis in this really high-risk patient group is really vital. Now, we had a look at whether it was an induction, a reinduction, or a consolidation for cycle 2. Didn't make a difference. We had a look whether they had HIDAC or CLAG for their consolidation. Didn't make a difference. Pretty much the only difference, which is demonstrated here in univariable regression analysis, is prophylaxis as a time-dependent risk factor. That's whether they had a high cytogenic risk, baseline ANC being low, the treatment cohort, it was all prophylaxis. There was a slight trend of their performance status. So if they weren't as, if they were a poorer player, if they were older and had more comorbidities, they were higher risk of fungal. And that's kind of expected, but it was much less pronounced than having that prophylaxis as a time-dependent variable. And we looked at that as a multivariable analysis, and it came through again that prophylaxis was the only risk factor. Now, we are also looking at levels of all the posaconazole of those 300 patients, and that'll be in the final publication. It's a little bit complicated to do a time-dependent analysis of being on or off prophylaxis, and do a time-dependent on top of that, time-dependent of whether they were have a therapeutic level or not. So there's a little bit of statistical challenge there, and that'll be in the next round, the next talk I give. So in conclusions, patients receiving contemporary chemo, like for AML and MDS, that very high intense chemotherapy are very high risk of a mold active, of invasive fungal disease, but appropriate mold active prophylaxis does seem to protect them to allow patients to be given that intense therapy, which will improve the outcomes of their malignancy and hopefully not then have an increased risk of infection in that treatment. So thank you very much. That's all I had.
I had to put in the chat, Julian, to apologise for the heavy use of acronyms. It's
yes, sorry.
It's very overwhelming for working in this space, because every time we go into a ward round, the haematologists all talk about these different clinical studies or different regimens, and they all use acronyms and literally have no idea. But there is.
I do apologise.
No, don't apologise. It's an explanation of why this area is an interesting one to work in because of that particular issue. But coming back to your point about risk, the one thing about antifungal stewardship, which is quite different to antifungal other stewardship outside of the haematology oncology wards, you actually need to do it in partnership with the clinical teams, and to build that relationship with them so that you can actually talk to them about any patterns or issues that you're observing, and they're almost always very open to hearing about it, because fungal infections do strike fear into their hearts, so they do want to know if there's a way to prevent it. And this sort of discussion around understanding what is a high risk regimen, they're very open to discussing. So you can always walk up to a haematologist and say, is this a high risk or low risk? And they'll say, no, this is really low risk. We're happy with fluconazole. No, this is high risk. Now I'm really worried. And so bottom line, leukemia is high risk, relapse leukemia is very high risk. And then we go from there. That's an easy lesson to learn. But I thanks, Julian. It's really important to see the emerging data to remember that, you know, these patients get pushed very hard. They get highly intensive therapy, and then they go through to stem cell transplant. So it's protecting them from an invasive fungal infection prior to transplant is really important to the treating clinicians.
Yeah, thank you.
And to illustrate that even further, we're going to hear about a couple of case studies from Beatrice. Thank you, Beatrice. I thought it would be really nice for the people on to hear the reality of what some of us deal with on a day-to-day basis. So over to you, and then hopefully we'll have some time for chats.
Lovely. Thanks, Kaz. So I've got a couple of cases just to present to sort of highlight the problems and the issues that we face with diagnosis and management of these patients. So in the interest of time, I'll just get started. So the first case is a 64-year-old lady who presented with lethargy and fever that then progressed to shortness of breath and cough. This is in a background of diffuse large B-cell lymphoma, which was diagnosed almost 2 years ago. And she had multiple lines of treatment and progressive disease in all of them, including traditional R-CHOP, RICE, and CAR T-cell therapy. Her current treatment was obinutuzumab, so anti-CD20 or B-cell, and glofitamab, which is a bispecific T-cell engager therapy. So bring the T-cells together with the cancer cells to engage them and cause more killing, which obviously has unintended side effects, which are not quite clear yet because all really in trial phase. Her other past medical history was relatively unremarkable to asthma, reflux, urinary tract infections, and previous PIC-associated clots. And of note, she was on prophylactic Bactrim and valacyclovir. So initially, she was diagnosed when she first presented at a peripheral hospital with pneumonia, and she was commenced on the normal cocktail of IV antibiotics, which was then downgraded to amoxicillin and doxycycline with no significant clinical improvement, which is when she was transferred over to us. This was about 2 weeks from initial presentation, and on arrival, she had a met call for hypoxemia and tachycardia with her associated productive cough. Her only other symptoms were sort of a left back pleuritic pain, and there was no other localizing signs of infection. So this was her CT pulmonary angiography on arrival. So it demonstrates this left medial basal consolidation. You can see the arrow there, but also a couple of nodules here and there, ground glass changes associated. Given that sort of lobar consolidation, it was thought that this was probably a run-of-the-mill community-acquired pneumonia in someone who was at risk. So she was continued just on ceftriaxone, but did undergo a bronchoscopy given her previous lines of treatment and current trial therapy. And from the sputum MCS and the bronch cultures, this grew in Aspergillus fumigatus. This is when we got involved, and at that stage, she was feeling significantly improved with ongoing cough and shortness of breath, but significantly better than previous. She had no further fevers, and repeat scans showed that consolidation in the left lower zone was almost all resolved, although there were still the ongoing foci of nodular branching opacity and ground glass changes, as well as on the right there, some subpleural reticular changes. So whenever I consider Aspergillus fumigatus or any other sort of fungi that grow in sputum, I think it's always a consideration of risk of the host versus risk of the pathogen. So things that contribute to host risk are things like their medical history, previous treatment, including transplant, what prophylaxis they're on, and other sort of markers of immunosuppression like cytopenias and hypogamma. In terms of the pathogen, because the lungs, as I like to tell the residents, are not a sterile box or a closed box, it's always open to the environment. So things like colonization is always important to consider, as well as whether the pathogen itself is a resistant organism, either because of intrinsic resistance or because we've made it more resistant. And then all the other things I like to ask about that patients always look at me funny for, exposures like pig shooting, cryptococcus exposures, red rubber gums and things like that. They're the fun part of ID. So in this particular patient, she has had multiple lines of previous treatment, including CAR T therapy. Her current obinutuzumab is an anti-CD20, so that's a B cell scorn. And we're not really sure what happens with glofitamab just because it's so new. But also of note, she was clinically improved, and it was her preference not to have unnecessary treatment. Aspergillus fumigatus itself, it's an environmental organism, relatively sensitive to most antifungals, but it is not insignificant in that it still has a very high mortality rate of up to 50% in acute leukes and stem cell transplant patients. And then of note, the galactomannan came back on her bronch, so quite high, 6.94 there. So the decision was made to undergo treatment. But there are some tools that help us make that decision, and they consider sort of the same things that I've highlighted already. So the EORTC criteria is most commonly used, and that considers your host factors and risk factors involved with that. So things like neutropenia, stem cell transplant, and corticosteroid and T-cell immunosuppression, as well as some of your inherited immunodeficiencies. It also considers your clinical criteria, including radiological criteria, as well as microbiological and mycological criteria, so what you've grown and other indirect tests. So in this case, this patient did meet at least probable diagnosis of an IFD, so of an invasive fungal infection. And so she was commenced on treatment and is currently doing well, tolerating her voriconazole without issue and good levels. But the lessons I think that are highlighted from this case are the consideration of the overall immunosuppression of the patient, including legacy immunosuppression, as well as the consideration of infectious risk in novel therapies like bispecific therapy, where this is not well delineated, as well as the use of decision-making tools to help assess risk. So the second case I have is relatively similar. So it was a 74-year-old lady who presented same sort of symptoms, increasing shortness of breath and suspicious pulmonary lesions on her chest imaging. She was also a patient with a history of diffuse large B-cell lymphoma, but she had been in remission since 2018 after relatively standard R-CHOP therapy that concluded in 2017. She did, however, remain on posaconazole prophylaxis, Bactrim, and valacyclovir, and that's significant. I'll come back to that later. And also of significance, her past medical history was significant for bronchiectasis with quite a few infective exacerbations, including 2 episodes of pulmonary nocardia and previous isolations of E. coli and an Aspergillus species, which is why she was on posaconazole through her treatment. And certainly that posaconazole prophylactic regimen makes me think of perhaps more resistant organisms that we might need to consider. Of note, she did also have secondary hypogamma, but was being treated with intravenous immunoglobulin replacement. So overall, I think if weighing up the whole situation, this patient is indeed at risk of something weird and wonderful or something invasive. Her CT imaging was relatively similar to the previous ladies. So she had new ground glass, rounded densities in the left lower zone, as well as progression of this left upper lobe opacity, which was attributed to be primarily from mucus plugging. She also underwent a bronchoscopy thanks to the respiratory team, and her fungal cultures grew Lamentaspora prolificans. And as is consistent with the organism, this was relatively resistant to all the triazoles and intermediate to terbinafine. She was commenced on voriconazole and terbinafine as combination therapy, but unfortunately developed a skin rash to the voriconazole, which was then ceased and transitioned over to posaconazole. So I'm sure in this setting, I don't really need to revisit this, but Lamentaspora is notoriously difficult to treat. It grows these black pasty colonies that you can see on the right there, and is geographically limited to ourselves, Australia, Spain, and US. Like most of the other fungi, it's an environmental organism in soil and polluted water, and risk factors are generally reflective of the degree of immunosuppression. So patients with cancer, cystic fibrosis, transplantation, and diabetes. While it has variable presentations, it has really high mortality rates, up to 90%, and that's probably reflective of the fact it's so resistant and the patients are so immunosuppressed. In terms of treatment, voriconazole is a first-line treatment, and that was based on a couple of studies more than about 10 years ago. Not terribly high numbers, but not too bad really, all things considered, and that showed about a 66% survival at best. In terms of antimicrobials, in vitro data is quite poor, as is retrospective data, but it demonstrates high MICs across all the antifungals. In terms of combination therapy, in vitro data once again demonstrates that VORI and terbinafine has perhaps the best synergy due to inhibition of the ergosterol pathway. And there's some retrospective data based on a registry study that demonstrated that this combination antifungal was associated with increased survival at 28 days. In terms of this posaconazole and terbinafine combination, the evidence of this is a bit more unclear and is primarily based on extrapolated in vitro evidence for posa and terbinafine. It wasn't particularly specifically tested, but the thought was that perhaps that might be a bit of a class effect. There have been some very, very small, and I must stress very small, clinical retrospective studies, and this is primarily in cystic fibrosis pediatric patients, which demonstrated this combination therapy did result in improvement or stabilization of disease, but was unsuccessful at eradication. This is probably not unexpected in CF patients. So this patient is also doing well. She's about a year down the track from therapy, and the problem we're currently facing is when to stop and what to prophylax with. But overall, I think the lessons learned from this case are the consideration of some more intrinsically resistant pathogens, especially in the case of mold active prophylaxis, and the need for novel treatment regimens for these pathogens. So I hope these two cases have sort of highlighted the day-to-day challenges we face with antifungal therapy, particularly that in diagnosis, treatment choice, and duration of resistant organisms. And I think it's really important that we get a good idea of what is being used and when, and hopefully that's what the NAPS survey will help us with. Thanks very much.
Oops. Sorry, trigger happy. Thanks, Beatrice. So just following up from your comments, many of you online, you might be a little surprised to know, but pretty much most audits of invasive fungal infections and indeed antifungal use have generally been done as part of a research activity. It really hasn't been part of routine reporting, and we only get a little bit of a snapshot from the NAPS data actually. I can see that Nadine Hillock is online. Just before we go out to questions, Nadine, do you want to discuss how you're dealing with antifungals in the NORSP? Can we make you talk?
I can give her access.
It'd be great to hear the NORSP as well, what you're doing with the antifungals.
Nadine has access.
Oh, good. Morning, Nadine. Sorry to put you on the spot, but it's an ideal opportunity while everyone's online to hear from you.
That's okay. To be totally honest, I'm working and listening to you at the same time. So tell me the question again. Sorry.
I'd love to hear from you about what NORSP is doing around the antifungals.
Yeah. So it's been 3 or 4 years now since we've included antifungals in NORSP and also included in our reports. So we've now got sort of 3 or 4 years of data. We still see a huge variation in usage, even between different hospitals that do have haematology oncology. There's still quite a lot of variation. And yeah, I'm not quite sure what else I can add to the conversation. I would love to have a student to look at our data, and happy to do some collaboration there if you want to, Kaz and Courtney. Any students out listening?
Yes, so we really do encourage thinking about how to utilise your antifungal data as well as your both from appropriateness as well as utilisation. And Brad Rockcliffe made a comment and asked about the use of olorofilm. Yes, Peter Mac is one of the olorofilm sites, so we have actually used it on a couple of patients. Extremely well tolerated, very low side effect profile, and one of the patients I recall had an indolent hematological malignancy with multi-site lamentosporum involving the spine with metal. And actually did extremely well for quite a long time until there was her disease progression. So we think that olorofilm is actually going to be a very important addition to the antifungal armamentarium. Are there any other questions from the audience this morning? Questions or comments? Pop them into the chat.
Nothing else in the Q&A, and then nothing in the chat at the moment either.
So there's been a lot of information this morning. So of course we'll be recording the session and putting it onto the NCAS website, but also just following up, Anna has posted 3 demos. So you're very welcome to hop on and have the opportunity to interact with Anna in detail about the audit methodology, and we hope that you can contribute to that first one. I think it's really exciting. In the last few minutes, I wanted to hand the floor over to Courtney, who's been working very hard on our Antimicrobial Awareness Week activities. So thank you upfront to Courtney, because she's actually been doing a huge amount of work. Oh, okay. There's one from Sarah. Sorry, I was on the wrong tab there. Is the risk classification table on the Evercare website the gold standard for assessing antifungal prophylaxis? Sarah, my recommendations, and in fact, I recommend this to everyone online this morning. The source of truth and the gold standard for our consensus approach in Australia is the consensus guidelines for antifungal use in adults and paediatrics that have been published in the Internal Medicine Journal. And there are a series of publication there, which includes, you know, how we develop the guidelines, antifungal prophylaxis in adults and children, as well as treatment for Candida, crypto, etc. Right now, we are actually developing a simplified website which will be accessible, that summarises all then, because they're quite a lot of reading, but we are actually summarising them all, and there'll be a dedicated website for the antifungal consensus guidelines that'll be accessible, and that'll have all the key tables for you. And I think it'll be a really nice resource. I'm not sure when they're going to be available, but pretty soon. But I'll hand over to Courtney.
No worries. Thanks, Kaz. Yeah, just while we have everyone online. So for the next month for our journal club, we're not actually running journal club because we have a whole range of other events. As it'll be Antimicrobial Awareness Week. So we have a face-to-face symposium on the Friday. You can attend online, but for those that can, we'd love to see you all in person. Our approach for the theme this year is a learning health systems approach to antimicrobial stewardship. The learning health system is a framework or a cycle of how we apply generating data to generate knowledge to then change practice, which are pretty much the core elements of antimicrobial stewardship. So the symposium early bird just finished the other day. If I'll provide all the links in the chat for you to register if you're interested. And I'll also put the link to our website, which has the symposium program, but also the week after we have a range of online webinar series, and these are free to attend online. Again, it'll be all in this link here that I'll post in the chat. And we're covering a range of topics from allergy delabeling, antibiograms, nurses in stewardship, antimicrobial stewardship in surgery, specific settings such as pediatrics, general practice, the immunocompromised host, and in aged care. So something to cover all topics throughout the program. So that's the program. On the website, you can see here there are the links to directly register to each of these webinars. And additionally, our other collaborators such as the CSIRO, the Queensland Statewide AMS program, and CRE Respond also have events that week that we are promoting. And then if you still want some more education, next week, the CRE Respond group are running a session I can put that link in the chat as well for people of interest. There are some other questions. Kaz, are you able to? Oh, Zoe's kindly shared some papers, and then
Christine, I'm not sure what you're referring to, what we've seen earlier. You want to expand on what you mean by that? So Lorafilm at the moment has been under clinical trial use, so it's not actually available. It was initially released as part of a clinical trial in high-risk patient in immunocompromised patients, and I understand from Monica that in about 6 months' time there's going to be a trial in non-immunocompromised patients. So that's what I know. So thanks very much, Courtney.
Thank you, and thanks everyone. And Christine, if you want to quickly clarify what you're referring to, but otherwise we'll stop recording, and hopefully we'll see you all next month, either in person at the symposium or online for our webinars.
And very happy if you need to contact us directly.
Yeah.
Good day, everyone.
Bye, everyone.
Thanks, Court. Thanks, Nadine. Sorry, it's a